This week on the BackTable podcast.
So what we've noticed is that the medical imaging has these hidden signals that the artificial intelligence models are able to identify. And we've seen some of these examples, for example, in our work where we show that the model can just look at a chest x-ray and tell you that this is from a black or white patient. And we've seen other people do similar work that is showing that you can just look at a chest x-ray and say, hey, this will be the healthcare cost, for this patient. And so it's an interesting area because it's called this opportunistic screening.
Welcome to the BackTable podcast, your source for all things endovascular and interventional. You can find all previous episodes of our podcast on iTunes, Spotify, and backtable.com. Now, a quick word from our sponsor.
The Concerto detachable coil systems are shaped around the variety of patients you treat. Explore real-world case studies and share your own with #ConcertoPatient on the Medtronic Peripheral Vascular Health Twitter channel @MDT-Vascular.
One of the biggest challenges clinicians face is not related to devices or techniques, it's the workflow. For conditions like aortic emergency, PE, and stroke, outcomes are impacted because it takes too long for treatment decisions to be made and for patients to receive therapy. Viz.ai leverages artificial intelligence to coordinate care and improve workflow and is trusted in over 1,000 hospitals across the US and in Europe. The platform uses AI to detect disease, provide access to high-fidelity imaging and patient information, and allows you to communicate securely through the HIPAA-compliant communication tool conveniently on your phone, desktop, or within the radiology workstation. No more asking the ED to send you a grainy picture or making countless phone calls to activate your teams. Visit Viz.ai to learn more. And now, back to the show.
I'm your host, Dr. Baheti, coming to you from Tacoma, Washington. I'm pleased to welcome our guest for this week, Dr. Judy Gichoya, interventional radiologist at Emory in Atlanta. Today, we will be discussing the topic of race in AI. Judy, welcome to the show.
Thank you so much for the opportunity.
Judy, your research has found extremely high accuracy for deep learning models in recognizing a patient's self-described racial identity based on radiology images. Can you help me understand more about the models?
Yeah, thanks for this question. So what we've noticed is that the medical imaging has these hidden signals that the artificial intelligence models are able to identify. And we've seen some of these examples, for example, in our work where we show that the model can just look at a chest x-ray and tell you that this is from a black or white patient. And we've seen other people do similar work that is showing that you can just look at a chest x-ray and say, hey, this will be the healthcare cost, for this patient. And so it's an interesting area because it's called this opportunistic screening and has potential for public health. But I hope that throughout the podcast, we'll get a chance to unpack what this actually means.
Absolutely. Okay, so not to be a total statistical noob, but can you help me understand how you figured out that these deep learning models could tell race based on chest x-rays and other imaging?
Yeah. So what happened was that we were looking at a problem where we saw that there's bias, there's underdiagnosis for, in chest x-ray, we usually have these 14 labels. They're very well, a lot of debate has gone around them, but that's what every chest x-ray data set has, and where we
the 14 labels, are those like DICOM labels that every chest x-ray has?
No, actually they are just pathology labels, like pneumothorax, atelectasis, pneumonia. So you'll find that sometimes you'll have atelectasis and pneumonia and people will be like, well, can you really tell the difference when you're just describing features?
Right.
So like, is it a diagnosis or just a finding? So that's a big debate. But some previous work before ours had shown that for 7 of these 14 conditions, the models don't perform well for Black patients. So when we started off, we were just saying, hey, maybe we show you diverse data sets that we're going to take away all this bias, but it turned out that it wasn't. And so we ended up coming in to figure out the why. And that's how we said, oh, wow, these models learn some signal that correlates to the race. And we thought that it was a mistake. And so ended up doing a lot of experiments just to try and figure out, is this a fake out? And it could maybe end up being something like that. We haven't figured out why. But we started looking at the models and what they were predicting. So when you ask about statistical, by what magnitude, we have this, if you look at maybe the AUC values for the models, which is very common to evaluate classification models, we see that it's around 96% for chest X-rays. So for every 100 chest X-rays, 96 would be correctly identified.
96 will correctly identify the race. Okay. You mentioned the kind of the confounding factors that you tried to correct for to remove possible bias from the algorithm or try and find the source of bias. Could you tell me more about what you tried to correct for?
So initially we started on chest X-rays and we thought, wow, maybe this is just a finding on chest X-rays. But it turns out that, so we started by bringing other modalities, breast, mammograms. We also brought the CT chest and we had some cervical spine radiographs. And it turned out that the performance was good. Now, it wasn't as good as the 96 in 100, but it was in above the 80s. And then the second thing we said, well, maybe these models maybe the Black patients in our population are pretty sick, and so these models are just looking at the disease and confounding on that. And so what we did was look at normal X-rays only, something without disease. Do we find the same finding? And it's still persistent. And then we looked at BMI, age, gender, and also sort of like some of the disease distribution. So for example, breast density changes with race. There's also bone density. And so we ended up trying all those as explanations and also eliminating them from the images to see if the performance would be different. And the performance dropped for most of those things, but it wasn't random because you have 6 radiologists on our team and our performance was around 50 to 55%, which would be like random.
I see.
Yeah.
Okay. So just for some contrast, how good are radiologists at predicting race based on looking at normal chest X-rays or normal imaging?
Yeah, this is not a task when we interpret studies that we think about, If you think about bias from a radiology perspective, it's usually that, at least in my training, people would say, oh, these are like bullets, call them granulomas. Like if you found someone with a lot of bullets, they can sort of almost guess or at least try and guess, where they come from. Or when you have nipple rings, they can try and figure out your, sexual orientation, or you'd see the changes in that. Most of us don't look at the image and say, oh, I think this is from a Black patient. And the history even doesn't have that information. So we found we were very bad. We were around 50 to 55. And this was just like a small sample because, it was a surprising fact. Yeah.
Absolutely. Yeah. So I guess you've looked at a bunch of different confounding factors to try and correct. So what's your kind of like your best guess as to how the algorithm learns to predict race? Like, what do you think is going on?
So I can tell you what we've worked on that we know that it's not. One, we thought it's maybe how X-rays interact with black, dark colored skin, like melanin. And since we still saw the same performance for MRIs, then it's not really an X-ray finding, And then the second thing is when we've done work where we segmented the lungs, we segmented, the soft tissues and the mediastinum and tried to use those as the prediction. And what we find is almost maybe around not 55 like humans, but we see a drop in the 70s. But what that tells me is that the signal is contained in both the lungs and the soft tissues.
I see.
The problem here is that the AI models are black box in nature. So it's very difficult to audit them, even on just normal predictions. You just look at them and say, okay, this is accurate or not. But it's very, very difficult to audit and figure out why did this model that required millions of parameters come to this conclusion. So that makes our work a little difficult. So we know that it's not the melanin. We know that it's definitely not, localized to one piece of the body. And what the current hypothesis we've been working on is that maybe it's something about the contours and bones, but it turns out that you need a lot of physics phantom images to be able to explore that further.
So I did read as part of the article, you said that the AI models would work on images that had so much information removed that a human reading it could not even be able to tell that it was an X-ray. Wow, that is just wild to me. Can you tell me a little bit more about that?
Say, if you have TikTok or Instagram, you usually put a filter above your image to change it, right? So we did something similar where we applied low pass and high pass filter. So it's barely like a gray image, that you're looking at.
Yeah.
If I didn't tell you that this was a chest X-ray, you really wouldn't know. And so, but we still see the models can tell you, oh, this came from a Black patient, 89% of the time, that's still very surprising because the difference with that is if let's say you're auditing a dermatology application and the dermatology application, you tell me, it doesn't work well for these 10 patients and you show me the 10 patients and I tell you, oh, look, your model is just failing on all dark colored skin, But in this case, first of all, we are terrible at telling what the rest of the patient is from the imaging. Now you're bringing a grayscale image. That's like a double mystery, that you can never be able to figure it out. Yeah.
Wow. Yeah. And I just want to touch on the point that this was generalizable across multiple different data sets in the United States. So it wasn't localized to one region, right?
Yeah. And we did even subsequently, not in the paper, we've had people reach out to test our model, so we had other institutions even test and that data is not included in the paper and it was still the same performance.
Wow.
So one thing to notice with this is that when you transfer an algorithm from one institution to another one, you have to fine tune, make it learn the local distribution of the data. And in this case, we did not have to do that. You just send the model and be like, oh, voila, you still have good performance.
Wow. Yeah. It's very interesting. Okay. Well, I think I understand the work a little bit better, but now let's get into what are some of the implications of this research?
I think the first most important thing is it's amazing to think that racial signal can be embedded in something that is not obviously visualized. And this also brought up a lot of debate. Is race a social and legal construct versus, a genetic phenomenon, especially when you can find the same finding across multiple imaging modalities, right? So you're finding it on the wrist, you're finding it on the chest X-ray, so is it just something that is related to genomics and ancestry that still makes sure, says that we're different? And that there has been a lot of debate about, the genetic differences versus the legal and social construct. And so I do want to clarify that for us, we defined the self-reported race as how you see yourself and how others see you. And that is in the social and legal construct. And so I think, that's one, that it's surprising that these models can see something that you're not even training them for, And the second thing is we have actually examples of models that are being developed that work better for Black patients. One of these is a knee osteoarthritis model. And what it does is that it performs better than the Kellgren-Lawrence score. Now, some people may not really read MSK, so you may not know that this KLG score is used for, determining the severity of the osteoarthritis. And this group, what they did is that they looked at the KLG score. And so could you develop an algorithmic model that listened to the patient pain score and show if that's better for mitigating disparities and also improving the people who become eligible for knee surgeries? And in turn, that would mean that they get coverage. And they show that the algorithmic score is much better than the KLG score. Now, if you come back and tie back to our work and where we tell you that, wait, this model can really tell you that this is a Black patient or an Asian patient or a white patient. So you ask yourself, is this good performance because the model learns that the pathologies for Black patients are A, B, C, D? Or is it a better model because it just learned, oh, this is a Black patient, And so you have to figure out, is that a bad thing or a good thing? But also remember, the society is changing, right? We never had anyone in our population, at least in our EMR, we don't record them as mixed races. So when you encounter these mixed races, how will your model perform if it's just, learning just the race of the patient? So that's sort of the background of why this type of work matters. So it's not necessarily because when people hear you're working in bias or, these disparities, we are not going to minimize that there's a lot of systemic racism, but, and we know that there's differences in what patients acquire in terms of the type of imaging, but we want to move away from victimizing or saying this is necessarily a bad thing to explaining the question that you asked, like, why does this matter? And it's for us to be able to build and audit better AI models.
Oh, wow. Yeah. No. And I think it speaks to the value of just saying that maybe a race agnostic model isn't necessarily accurate. So what you think is race agnostic isn't necessarily race agnostic. And I think that's something that probably a lot of people who are involved in this modeling community outside of the race and bias spectrum would like to say that their software is race agnostic, but it truly isn't.
And one other thing I just want to follow up with your comment is that just because you didn't include the race label doesn't mean that your model is race agnostic, right? So we saw that with the Apple credit cards, right? Approving.
Oh wait, no. Tell me about that. I don't know about that.
Yeah,
I'm not a big news reader. So yeah, tell me.
Yeah, so when Apple introduced their credit card and they were pre-approving people, if you're married, they would give. So let's say you make more money than your partner, and but your partner would get a bigger sort of like limit on their credit card, despite you having a better score and more income. And what they said basically was, hey, we didn't put any gender information in the cards, but this data carry that signal, and the AI models are built to detect these signals, which is how we end up in this conundrum.
Absolutely. Oh my goodness. I'm learning so much. Thank you. Okay. So can you think of any way that this can really affect us in the IR field?
So, most people, every time I would say, over the years, people would say, wow, AI is going to replace radiology. I don't think, clearly it's been many years and that's not happening. But I would say that's why I chose interventional radiology, so not necessarily, honestly, from our work, except when you think about the oncology line, right? So we're seeing a lot of work on precision medicine that's merging imaging and pathologies, right? So we're seeing, hey, could you tell me who's a better patient to treat, right? So we know that a lot of IRs work in the IO space. And if you don't know that, there's quite a lot of this type of models being used to think about treatment response, to even triage patients to determine what they should get. And so that's, I think, going to be more of like an indirect way that, we may get a referral, but we really don't know why the criteria came, but we don't see quite a widespread use, but there's a big momentum, lots of IP around actually this phenomenon. And in terms of IR, I think the most thing that's going to affect us directly is the use of robotics for our work. Remember, those are also AI driven, and so we're going to see a lot of task shifting or ability, like I dislike browsing lang noding, so if the robot can help me do it.
Really?
Yes. Yes. Especially the sub-millimeter fiducial marker placement. It just doesn't spark joy.
God bless you for still doing those. Oh my.
So I think we'll see more of those robotics come for. And then the other area, this is not necessarily AI driven. And, we don't see this sort of predictive algorithms a lot, but we see a lot of this coming into IR is this image fusion, right? So, let's say, and we're seeing some of these tools being developed, which is, for example, like the virtual angiograms. So maybe if I'm just planning my study for tomorrow and you have a tough PAE, no one likes to do PAEs, but, if you're planning this, you could, if you have a good pre-procedural, MRI or CT, could you start to mark like, if my catheter is here, how will the enhancement look, right? So then you can imagine when you're in the room, you know exactly where you're going and how maybe I should be angling this angle at, 30 degrees LAO or, 45 degrees RAO to get into this difficult vessel. So we see quite some work being done. I don't know that it's ready for prime time. At least the products I've evaluated, but the big thought is to try and move us to sort of like an assistive tool. But I think that's going to be amazing for us,
Oh gosh, yeah. I think that sounds like it would really help with procedure times and patient comfort, and accuracy.
Yeah.
Yeah. So that's kind of how the best case scenario is, right? That AI helps us with our work, doesn't take over our jobs, which
I don't think it's going to take over. Yeah.
I mean,
yeah. You see quite a lot of this in neurospace, right? In neuro, right?
Yeah.
With the IR, interventions for stroke, right? So it's quite increasingly an AI-driven workflow about activating the stroke team. I think that the technology has changed. You shouldn't deny that, but I think it's definitely going to change how we work. But most of us are not involved in this development. So, for example, if you want to do something on fluoroscopy, we never store the fluoroscopies, right? Unless you're doing a DSA or you do a fluorosave, and that type of information where you could go back and say, okay, I'll use this as my data is very difficult to label. So that's how we are a little bit we don't see much activity being done there. Now, there is a cardiology suite application. What they've done is that they're dynamically understanding what phase you are, let's say, and cardiology may be a little bit more straightforward because you have very specific vessels that you're, cannulating. And it's when you do your run, it's going to decide, okay, this is LAD, this is the amount of stenosis. And what it does, it starts dictating your report while you're doing the procedure.
Oh, okay.
Yeah.
Okay.
So then, but can you imagine something like that for IR? One day you're exchanging the refractomy tube, the next hour you're doing a TIPS, the next hour you're doing a biopsy. I mean, we are all over that's what makes it complex, because AI tends to be more narrow focus, narrow use case, more than general tasks. But I know that I would enjoy something that dictated my reports, and they just had to.
Don't you have fellows? I'm just messing.
Yeah.
You touched on this a little earlier before our break, but you mentioned kind of marketing the results of this to the general population so they understand your research. Tell me a little bit more about what you've learned from that.
So this is a skill that everyone has. If you're doing research, or whether you're also just speaking to your hospitalist or whoever you're speaking to, communication is just so key. And one thing is to make the message clear, and also to make the message simple, this art of scientific communication, right? And because the doctors on the team quickly understood why this matters, but the computer scientists, and we had a lot of them on our team, they didn't understand it. They just said, you show me one case, I'm going to build a mathematical model and it's going to solve your problem. And we all know that bias cannot be one solution, and especially because, just because you include patients does not necessarily mean that you're going to eliminate bias. So representation is not adequate in just itself, and I give this example in the real world where you could be very, friendly to gay, someone who identifies as, gay, but on the other hand, you could be very, disadvantageous to the same gay Black woman or something like that, or lesbian Black woman. So just because you include them, they may have many facets that they identify with. And we see this in terms of the data sets that we build. I give that example because it was my experience in Portland, very, very a great place to be queer, but a terrible place to be a Black person, And so, but when we think about that, generally you'd be like, oh, that's the most diverse place that you could be in, And so, if you think about some of the data sets we build, just because you include the patients, if you select them poorly, then you'll include the patients who are not representative of everyone. And so this is a big challenge of data set building. And we don't even know how to measure it. People are just starting to develop techniques of how to do that. And I think it's, so how do you communicate something like that to developers or people who just want, give me my data, I'm going to build my model and move on, So it's almost like a negotiation. So it made me think, to make it simple, make your work reproducible. So release what you can so that other people can repeat the experiments and give you validity. And something that's not used in medicine is, not in medicine, because there's actually something that's come up, like it's frowned upon in medicine, is if you can release your work as a preprint. And what this means is you release your work before it's peer reviewed. And other people
I think that's what you did with this paper, right? It came out like last fall, I think, and then was peer reviewed and then came out again later.
Yeah, because
how did you get the idea? Yeah, how did you get the idea to do that?
Because it's very common in computer science. Some of the biggest papers have never been peer reviewed, which is it's a little unimaginable to think about in medicine. But this allows people to give you feedback, and you can improve your paper. Then the other soft skills are, luckily for us, the media picked it up, but if you have a media office in your institution, you should use it. We never use press releases when we've done like an amazing case in IR. you still don't share it out. Or the second thing is you also don't, for example, you can use your social media a lot. Increasingly, this is something I've seen people do not necessarily aim for the top tier journal. They just look for a good journal that's going to peer review your work and then use the social media strategy to get it out there. So there's quite a lot of like
really
these soft skills around research that I didn't understand, and also how to package your work and make it readable, else your message gets lost. So this was discussed on Reddit. There's a very active Reddit comment. There's a Twitter tab. I mean, it was everywhere. So I mean, I've enjoyed some comments are offensive, but I've enjoyed sort of getting the citizen feedback on it.
I mean, isn't it amazing? You and I are both about the same year out of fellowship, right? But it's amazing all the stuff that I'm learning now as an attending that I never thought would have been important when I was in training at all.
Yeah.
And the sources too, right? The sources of where we get our information is almost completely different than it was even five years ago.
Yeah.
So just a really exciting field to be in, really exciting time to be in IR. Sounds like a really exciting time to be a researcher too.
Yeah, I mean, but it's this, I call it this IRness, and I reflect this on the end of my training at the Dota Institute, because I feel that was also the turn of an era, because when I came to be an attending at Emory, so I'm saying that it also sort of this lifelong learning or on-the-job learning reminds me of sort of my feeling at the end of my fellowship at the Dota Institute, which is that, by the time I had never used some of these like advanced devices because we just didn't have them, and we would steam catheters and, there's just sort of like this, that this was not unusual to come up in the morning and just look at you only had like 2 catheters on the table, actually one and a Benson wire. And so, but to come in and you have like a rack catheter to get into the uterine arteries, you're like, what?
What is this? Yeah.
Yeah. And so what I would say is that it's this IRness, and I hope that, people describe it in different ways, but when you're in a problem, you're always thinking of how to get it better. There are many products, I'm not going to say them here, that I feel like they died because they moved away from IR. If they had stayed with IR, you would not be putting a big shit every time if it causes you bleeding problems and you're closing out, because you'd have figured out how to make it better. So this innovation and thinking are always about this problem-based thinking and this openness to learn new things as you move forward. It's a balance between the arrogance of I can do everything, but I'm lucky that I'm also in an institution where, some of the people I work with are always thinking, like this, and
absolutely.
It's super rewarding and I don't think it's something out of our breed as IRs.
Well, awesome. I feel like we've had a really comprehensive conversation about this. I guess one question for you is, what kind of future directions of research are you looking at in regards to your findings?
Yeah, so we're trying to do the harnessing. There's 2 things. One is figuring out, could you get better explanatory tools around this problem? And the explanations are also very debated. Like, do you really need explanations? And the reason for that is, if you think about MRI or some of the equipment we use, we know when they don't work well, but we don't necessarily know that, we don't necessarily know like the intricacies of, let's say, how, a specific type of modalities develop. And so people have debated what's the balance that's acceptable for AI. Do you need explanations, or you just really need to know when it works and when it fails? And those can be very different things. And so one of our things is to figure out, can we quantify this signal so that we can penalize the model and see how does it perform when we remove that signal? So we've done some work that's called adversarial debiasing, where we remove that signal and we see, well, do we still have good performance for the model? And this just helps us to figure out when the models fail. And so we're doing quite a lot of work on that. The second area is expanding this concept. I started by saying, we found out race, but we're starting to see all these other models, and it's these hidden signals. And I mentioned something about opportunistic screening. So we see, for example, patients who may come to the ER, and we know that CT is becoming increasingly the mainstay of screening for chest pain. And, a lot of AI is being applied to such a problem. But not everyone with chest pain, will come in with, get a gated CT, chest. And so they may get an uncon CT because maybe they're coughing and someone just wants to look at the lungs, or you're in contrast shortage and you just got a CT chest without contrast. And so this opportunistic screening takes these images that are done for something else and starts to look, can you start to develop cardiac risk markers for population? Can you start to look at the fatty liver just because you're cutting the top of the liver on a CT chest and start to figure out the cardiometabolic risk for the patient? So that's, I think, really interesting work. And then maybe one of the other projects we're looking at is, could you compound all these images and give you a sense of the social determinants of health for a patient? Because maybe, I live in an area where there's a lot of pollution, so maybe there's some subtle changes in the chest. These are all hypothetical. Probably we'll know at the end of the year. And I walk 10 miles to work, so my knees show a lot of wear and tear. So could you start to get a different profile for the patient that helps you figure out what their outcome will be?
I love that. Just personalized medicine, right? That's the goal, kind of. Okay. Is there anything else that you'd like to talk about in this podcast? Anything we missed?
No, it was amazing. Yeah.
Yeah. You are doing really important research. I'm so glad there's people like you that's interested in this, because I love learning from you. And I'm so glad we finally got to talk, because I feel like we have a lot in common. Judy, thank you so much for...
Yeah, thank you so much for the invitation. I'm a big fan. I listened to the ones, especially on the Road to IR program. And so
Yeah. No, it's a great platform. I'm lucky to be involved in it. Okay, well, thank you so much, Judy, for being on the show today. Take care.
Thank you. Bye.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dond,
Michael Barraza,
and Ali Baheti.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson,
Josh McWhirter,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson
and Delaney Aguilar.
Social media and PR by Ann Dang.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening, and see you next week.